Good morning, Dr. Miller.
Hi, good morning, Dr. Putri. How are you?
Fine, thank you. Thank you for
Good.
joining us here now.
Absolutely, my pleasure. Thank you for the beautiful graphic. It is the best
Good
confirmation
morning,
of
Dr.
a
Miller.
talk that I think I've ever. Good morning, Dr. Putri. How are you?
Fine, thank you. Thank you for
Good.
joining us here now.
Absolutely, my pleasure. Thank you for the beautiful graphic. It is the best
Good
confirmation
morning, Dr. Miller.
of a talk that I think I've ever. Good morning, Dr. Putri. How are you?
Fine, thank you. Thank you for
Probably.
joining us here now.
Absolutely, my pleasure. Thank you for the beautiful graphic. It is the best
Good
confirmation
morning, Dr. Miller.
of a talk that I think. Hi, good morning, Dr. Putri. How are you?
Fine, thank you.
Give us some time to make sure what is happening.
No problem.
Okay, I think the problem is solved. Good morning, everyone. And I hope everybody is also in good health today. Assalamualaikum warahmatullahi wabarakatuh. Today we have our first American Society Plastic Surgeon Visiting Professor program with Dr. Randy Miller from University of Miami. Hello, Dr. Miller. Welcome.
Thank you very much. Well, thank you for having me.
We're very pleased to have you here today. But before we start your lecture today, I would like to ask our plastic surgery program director to give a few words.
Please.
Dr. Pastia Nugraheni, the time is yours.
Thank you, Dr. Melati. Assalamualaikum warahmatullahi wabarakatuh. Welcome, Dr. Miller.
Hello,
Thank you
hello.
very much. Thank you very much for visiting us and traveling so far from Miami, even though it is virtually.
I hope to do it in person. In person would be better, but
Yes.
this is good in the interim. Yes, thank you.
Yeah. Well, we hope in the near future we can host you in our residency program. So,
Great.
this is a collaboration between our residency program and the American Society of Plastic Surgeons because our national society is a member of is a global partner of ASPS. So
Yes.
we benefit a lot from this collaboration. We get our resident into the international trainee membership and get access to the ASPS contents, education contents. And also we get this excellent program of the visiting professor. So we wish that we could continue this program regularly, maybe up to 6 months, once a month. Maybe we can discuss it furthermore. For an overview, our residency training program was started in around 1980s, 89 to be exact, and the first residence was accepted in 1990. But the plastic surgery service in our hospital has already started since 1959. So
Oh
our
wow.
first plastic, yeah, our first plastic surgeon went to Washington University for studying plastic surgery there. And as soon as he got back, he started the plastic surgery service in our hospital.
Oh
But
wow.
the official training program started around 1990s. But before that, we have also several seniors who come to the hospital and do some fellowship with senior plastic surgeons.
Hmm.
So in our plastic surgery program, we have several sections. One of them is this wound and burn section. So
Okay.
Dr. Malati is from the burn and wound section. So we thought that this is a very good opportunity for us to have a collaboration with you, since Dr. Randy Miller is an expert in stem cell research and also application. And our seniors in the burn and wound section already started several studies in stem cell, but maybe we need more insights and well, I'm pretty sure that we can benefit a lot from this collaboration with you. So, well, we hope in the near future you could visit us in Jakarta in
I would
real
love to.
person, and maybe Dr. Nandita and Dr. Aditya and Dr. Ahmad Noviandi and Dr. Narotama, who are in the burn and wound section, could also
Mhm.
visit your center one day. Because I read in your website that you have a stem cell research center, so I think it's a really good opportunity for us to collaborate. Okay. And also for our
Absolutely.
residents, yeah, for our resident, we send several residents before to several center in the US for observership. So maybe if you're interested in stem cell research, maybe in the future, you can go to Dr. Miller's centers and do the observership. And for the time being, welcome and please
Thank you.
enjoy Dr. Miller's lectures. And at the end of the lectures, please don't be shy to ask question, a lot of questions, because this is a rare opportunity for us to have such a giant in the field. Okay. So without further ado, maybe I will give the time and place back to Dr. Nandita to start this lecture. Okay, thank you.
Thank you. Thank you for your kind words.
Thank you, Dr. Henny. Yes. Before we start with Dr. Miller's lecture, I would like to read a bit of your biography. So
Okay.
Dr. Randy Miller is a board certified cosmetic and reconstructive plastic surgeon practicing in Miami, Florida, USA, certified by the American Board of Plastic Surgery, also a past president of the Miami Society of Plastic Surgeons, the Florida Society of Plastic Surgeons, and the Plastic Surgeons Patient Safety Foundation. That's a lot of past president of yours. Okay.
A lot of activities.
Yes. He is also a member of the Physicians Council of the American Association of Tissue Banks, a clinical professor in the Division of Plastic Surgery at the University of Miami, serves as a plastic surgery resident mentor, and also definitely an internationally recognized expert in the fields of stem cell research and therapy, including human tissue regeneration. Also, Dr. Miller has also founded the American College of Regenerative Medicine. With such a great resume, I think we will have a very great lecture for our first lecture today. And the title will be the evolution of adipose transfer from microfat to nanofat. Thank you, and the time is yours, Dr. Miller.
Thank you. Well, I have to say that it's a tremendous honor to be with you. I was just on a conference call with ASPS, and Dr. Greg Evans sends his hello. I don't know if you know Dr. Evans very well, but he was my professor at MD Anderson when I was doing my residency, and really is the kind of the creator of this whole international collaboration that we're doing. So he sends his hello, and then we just have to tell you that from our perspective, we're very proud of the work that you guys have been doing. We say guys in US, but we mean guys and gals and men and women, but your crew and the dedication that you guys have to to this medical education is tremendous. And it was really the idea of Dr. Murphy and Dr. Evans to create this panel where we can reach out, and also it's our opportunity to also see who's out there and learn from you as well. I mean, we have had so much good experience with international collaboration, and there's good plastic surgeons and all over in every part of the world, and the more that we collaborate and learn from each other, the better it is. So I'm honored to be here. It's a pleasure. And again, I would have to compliment I asked Dr. Putri for the confirmation. I was expecting maybe like 3 or 4 words saying confirmed, but then I got this beautiful graphic And I said, oh my gosh, this is just tremendous. So thank you for making me feel so special. And I hope I can share some of my experience with adipose transfer and stem cells and whatever else that we can collaborate and share together. It's my pleasure. So thank you. So can I get some direction on how to share my screen? Or okay, let's see. Let's go to Zoom. No. Is this it? No. I think this is. Okay, you can see?
Yes.
We can see very well.
Okay, I have the right. Let me go to the beginning here. Okay, so this is good. You can see?
Yes.
Yes, Dr. Miller.
Okay,
Perfect.
great.
We could see it.
Okay. My generation is a little bit behind, so I'm catching up. So anyway, all right. So so basically, I'm going to talk about the history of adipose transfer and how we evolved from macro fat to this concept of nano fat. These are just some disclosures I have, and none of them are will have any impact on the content of this talk. So in the 1980s, when we were performing adipose transfer, we were just taking large chunks of adipose tissue and just moving it somewhere in the body to kind of create a fill. But the problem was that we didn't, understand that these large grafts are supplied by, a robust capillary network and arterial and venous vessels. So the grafts would die and they would necrose, and we didn't really understand the concept of microfat and how we have to use the concept of grafting to transfer adipose tissue. And so it wasn't really until this amazing gentleman, Dr. Sidney Coleman, who we know and we love, and when I was in Texas in the 1990s, my chairman, Dr. Melvin Spira, went to New York City and trained with Dr. Sidney Coleman and came back to the Texas Medical Center. And we started transplanting fat in all kinds of cases, in cosmetic cases, in reconstructive cases at MD Anderson. And we really were seeing, we didn't even know that there were stem cells in fat at that time, but we were still just kind of getting the concept of adipose grafting and how we can do this successfully. And what Dr. Coleman showed us is that this structural fat grafting is, placing little adipocytes, little particles of adipose tissue in these discrete tunnels can facilitate revascularization. So each one of these adipocytes can regain its blood supply. And that's how we get this concept of structural fat grafting. So when we're doing the technique of fat grafting for structure, we're always harvesting adipose tissue, of course, and then we're processing the adipose tissue, and then we are injecting the adipose tissues. So that is regardless of what kind of harvesting technique we're using, whether it's a handheld aspiration or it's a power aspiration system. Regardless of how we're processing the fat, are we resizing it? Are we washing it? Are we doing a centrifuging with the Coleman technique? And how are we injecting? We're always putting the fat back in and transferring the adipose tissue. So these are the three components that are there, but there's a lot of variability with each part of the process. So this is a diagram that just shows the proper level of adipose harvesting. We found that if you get too superficial towards the dermis, that you can get a lot of bleeding and bruising, and you also are at risk for contour irregularities. So we really like to be beneath the layer of the superficial fascia, and that's kind of our sweet spot. Adipose tissue is very complex. It's very heterogeneous. It's not like one smooth tissue like blood or bone. There's lots of fibers and nerves and blood vessels. And I will say honestly that when we work with adipose tissue in Miami, many times by accident, we get it on the floor or we squirt it on the ceiling by accident. And we say that we have a joke in Miami, we say that fat is a messy business. It's a messy business because it's a very difficult tissue to learn how to manipulate. And a lot of times you can get clogging of syringes and you can get, different things like that. So it's an adventure and there's a learning curve there. But we're always using a tumescent technique when we're harvesting the fat. And we're always using some kind of lipoaspiration, some kind of negative pressure to draw the adipose tissue out of the body. Now, whether we're using a handheld technique or a power aspiration technique, that's a significant question. I'm going to close my door because the cleaning people are here. It's 8 o'clock at night, so excuse me just for 1 second. Hello. Okay, sorry about that brief intermission. So the question is, are we using a handheld technique or a power aspiration technique? And we do both of those, during the process of adipose transfer. So with the tumescent fluid, we are using the standard Klein solution. We're using, 500 mLs of injectable saline with plain lidocaine, 2 amps of epinephrine, and some sodium bicarb. And I can say that before COVID, I was lucky enough to be in Shanghai with Dr. Klein and learn all about the Klein formula. And it was fascinating to kind of hear his experience and his journey through tumescent liposuction in the very beginning. So with the handheld technique, we're using that for small volume harvesting. And if we just need a little bit of adipose tissue or it's in a very concentrated area, but it's very difficult to do handheld aspiration if somebody's had previous liposuction or they've had a harvest in that area because they have a lot of fibrous tissue and it's very difficult to maintain a vacuum or negative pressure. So that's where we started doing a lot more power aspiration, and we can get a lot more volume if we need it. But also if patients have had previous liposuction, it's difficult to go in with a handheld technique and harvest adipose tissue and maintain a negative pressure. But if you have a power aspiration system, then even if you're in an area where there's air in the pocket, you can still create negative pressure and harvest the adipose tissue. So that's a benefit. And of course, if patients have had previous liposuction or previous adipose harvest in that area, that's an indication automatically for a power aspiration type system. So what is the best cannula to use for these adipose harvesting, for that process? And we're still, looking at that and trying to figure out what is the best geometry, what is the best port size, what is the best configuration. I've been working with a company, which I believe is in Indonesia, as Tulip Medical, and they really have been very helpful in the plastic surgery world in general from the very beginning, early days of liposuction, all the way through fat transfer, and now into the world of stem cells and regenerative medicine. But they have allowed us to kind of express our ideas and work with us and develop different harvesting cannulas. And these are all different Tulip harvesting cannulas for the same type of procedure. So Dr. Caraway has his cannula, and then of course I have mine, and then Dr. Patrick Tonard has an aggressive cannula, but he's a master, so it works well in his hands. To me, it looks scary, but to him, it works perfectly. And then Angelo Trivisono in Italy, he has a different concept of how we should be harvesting adipose tissue. So I'm not sure we really know the best way, but we're, continuously working on the process to see, how we can make it better, how the patients can retain the adipose tissue longer, safer, how we can be less traumatic with the harvesting process. So these are all different things. So important factors for the cannula: the port size, the shape of the ports themselves, the configuration. Are they right across from each other, or are they in a spiral configuration? And what is the cannula length? When we designed these cannulas from the beginning, they were so long that I called it like a Zorro pose, like you're going to put the, you have to stand 3 feet back to put the cannula. That's a very uncomfortable. But if you're using a handheld technique and you use a cannula that's only 5 or 10 centimeters, you lose your suction right away, because it's right there at the surface, like where you introduce the cannula into the skin, and you can't maintain the suction. So we found that 15 centimeters is kind of like the sweet spot for the adipose unfamiliar who don't want to go like this, and then for us who we want to maintain a suction in the cannula, in the process itself. So this just shows, this is a single-use disposable infiltration cannula made by Tulip. And basically what we're doing is we're taking the Klein solution, putting it in to this area of the abdomen to harvest adipose tissue. And these are procedures that are done like really easily in the office, under local anesthesia. And it's rare to see somebody smile and be happy, while they're having surgery, but we're getting the adipose tissue removed. So that always makes people happy. And we're, doing it without pain and without, without discomfort. And the cannulas are single-use disposable. So we use them and we throw them away. And that's really, really key. We've had some issues with mycobacterial infections here in Miami recently, some very prominent fat transfer surgeons. So this is a real problem, especially with cannulas that are used frequently. So that's the infiltration, and this just shows the kind of that sweet spot below the level of the superficial fascia. And then this is after we put the Klein solution in and we let it sit for like 15 or 20 minutes. Then we do this handheld aspiration technique. And basically I created this, what's called a Miller snap, for a 60 cc snap for Tulip. It's a disposable instrument or piece, a disposable piece. And basically what we do is we put it onto the plunger of the syringe, and then we put the plunger all the way in, attach it to a single-use disposable harvesting cannula. And when you pull back on the plunger, it locks that negative pressure into the syringe, and you can harvest adipose tissue with very little bleeding, again, under local anesthesia, without a lot of discomfort. And at the end, you could just throw the cannula away and you have a very nice adipose tissue to work with. So that's the handheld technique. Now, this is the power aspiration. This is kind of my preferred system. I like this, the Human Med. It's a body jet or water assisted liposuction, which was very popular in Asia, and it really was slow to catch on in the United States. But now we brought it into plastic surgery and even into the stem cell world. It's really been shown to be a great technology. And again, we can do these cases in the office. You can see that it's a higher volume aspiration, but when you get this adipose tissue out, the beautiful thing about the technology with Human Med and the water-assisted liposuction is that the jet is in the middle of the cannula, and so the particle size that comes out is absolutely beautiful. So you don't have to centrifuge this. It is like ready to inject like right away. So if you have a case where you're going to do, breast reconstruction or high volume, you can actually do this. Again, this is all single-use disposable instrumentation that we can do in the office. And you'll see that the quality of the adipose tissue, when you draw it up, you can see how beautifully it comes up into the syringe, and there's no tumescent fluid in it. So it's like, it's just amazing. I mean, we've had such a good experience not even having to centrifuge that, and it's ready to inject. So that's why, for me personally, I think that system is really the better system. So now when we take that fat and we're going to transfer it into different areas, my phone is blowing up with WeChats here. So I don't know why that is. Anyway, so when we do microfat when we take that adipose tissue and then we're going to transfer it into an area of the body, you know, you want to have that Coleman technique. You want to have that structural fat grafting. And you want to be able to, you know, have the adipose tissue be maintained, you know, in the, you know, for longevity and revascularized. So microfat is great, and it's great. We're using it for breast augmentation. There's a lot of ladies that are coming in, and I know this is very popular in Asia as well. Is the, you know, adipose transfer to the breast with implants, and now we're taking implants out and putting just adipose tissue in, which is really working very, very well. Again, using that Coleman technique and, you know, minimal manipulation of the adipose tissue. This is an example of using single-use disposable injection cannula for adipose transfer around the mouth, the perioral area. This is a lady who was a previous smoker. And, you know, I injected 45 cc's around her mouth, and I was so scared that I thought, wow, 45 boxes of Juvederm or 45 boxes of Restylane. I can't imagine, you know, how that's gonna, but it turned out that she probably could have used more than 45 cc's of fill in that perioral area, which I'd never done that kind of volume before, but this is a case that really required that, you know, so this is just an example of that. So then we started doing all this fat transfer, and we started realizing that we use smaller particles and using microfat, but then we started seeing complications from other doctors who were doing something we've never seen before, and that is to injecting fat, microfat, into the lower lids. And so we're seeing these complications of patients coming into the practice, and this is a real problem. I mean, this is a very complicated thing to fix. And, you know, you have to go in there and take those pieces of adipose tissue out, and it's a mess, you know, with lower lid retraction and that kind of thing. So we knew that, you know, injecting microfat into the lower lids was not going to be something that we could deal with. So we have this thin skin, like no subdermal tissue. You know, we had to figure out a way to get the adipose tissue or the components of it into the skin itself without being lumpy, bumpy, and having contour irregularities. And so that's where we kind of came up with this concept of nanofat, was that we have thin skin, no subdermis. We need to get it into the dermis. We want it for regeneration. And the key thing is, we're not necessarily using it for the fill. It's not for like a tear trough correction. This is for, you know, texture and quality of the actual skin of the lower eyelid itself. And so this is really for, you know, stem cell component, and not really for structural fat grafting or filling. And you know, I think we owe a huge debt of gratitude to Dr. Patrick Tennard. He's a genius. He's honest. He does beautiful work. And, you know, he told me the story of where they took curtains off of the hotel in Belgium, and they used the curtain, the shear of the curtain, to filter the adipose tissue in the very beginning, in the very first cases of how they started it in this endeavor. And I think we have a lot of, you know, really a really huge debt of gratitude to both Dr. Tennard and Dr. Alex Verpale, who have, you know, done beautiful work and have really led us into the science of nanofat. And so basically we've kind of like taken these big chunks, like we talked about in the beginning, and of adipose tissue that didn't really work very well for transfer. And then we're now talking about transitioning to microfat and Dr. Coleman and structural fat grafting. And now we're talking about, Dr. Patrick Tonard and stuff that, that we're doing here in Miami with nano fat. It's kind of like this very interesting evolution and transition of, of utilizing this type of material. So nano fat is basically just a filtration of adipose tissue. And at the end, you get mostly just stem cells and exosomes. There's no adipose tissue left in nano fat. So it's kind of a misnomer. Nano fat doesn't have any fat, really. It's basically just a regenerative component, which is a very kind of oily based system that does not have a lot of adipocytes in it at all. As a matter of fact, if you look at it, it's so different from, nano fat is on the left and macro fat is on the right. And you can see the nano fat is very much different color. It's much, much more liquidy. Again, nano fat on the left with much more liquid component to it and not very much adipose tissue in there at all. And when you express that through a cannula, you can see the nano fat is much smoother in its application than the microfat, which is kind of comes out in little clumps. So nano fat is kind of liquidy. And as Dr. Tonard and Verpel showed, staining, the green stain is for adipose tissue or adipose cells. And as you go down to the bottom, you see that nano fat is basically not staining for adipose tissue at all. So again, just kind of like emphasizing the concept that there's no there's no fat in nano fat, which is kind of interesting. But Dr. Tonard, this is what they did in the very beginning, was just take a 30 gauge needle and inject it right into the skin, like not into the subdermis, not a blunt cannula, but a sharp needle injection, into the skin itself. But you cannot argue with these results. This is a 15-year follow-up, and you just cannot get this improvement in the texture and the quality of the lower lid with any laser, any machine, any cream. There's nothing that can do this like nano fat. And it's basically autologous exosomes and stem cells from adipose tissue, used for these type of treatments. And you can use it for fine lines. Again, it's not really a filler, but you can use it in this very superficial areas. And a lot of these correction of the crepey skin in the décolletage area, getting very, very good results with just injection of nano fat right into those creases. Again, not necessarily for a fill, but just to repair that damaged tissue in those particular creases. Now, I had a debate with Dr. Tonard that I said maybe we could put nano fat in through blunt cannulas. And he said it will never work because you're not going into the skin. So I sent him this video and I said, well, I'm pretty close, to the dermis because the skin is so thin. But I'm getting the sense after seeing these patients for quite some time that the improvement is really happening more with injection in the skin, and I would stand corrected that Dr. Tonard was really more accurate in the best way. This looks good, and again, the skin is very thin. I'm sure that there are some stem cells and adipose tissue going into that dermal tissue, but it's not really necessarily intracutaneous as much as that is subcutaneous, and I'm not sure that's the right way. So maybe I'm showing this to show you maybe what you may not want to do it this way, but I think the needle injection is more effective. Now we are also using microneedling with nano fat and PRP, and that's also helping us with intracutaneous delivery of nano fat, and also with a combination of PRP. Interestingly, PRP is activated when it touches the nano fat, so you can't put them together. So you have to use them separately, but you can use them in combination with some very, very good results. And this is another example of pigmentation improvement in the lower lids. So the pearls for adipose tissue transfer, what is your indication? Are you trying to create a breast? Are you trying to contour a buttock or a torso? Or are you trying to restore the integrity of the lower lid skin? What are you trying? What is your goal? What is your indication? Are you going to be using adipose tissue for a filler or for a stem cell or both? Sometimes you can use different components of the same material for a dual type of a treatment. How are you going to harvest the adipose tissue? Are you going to use a power technique? Or are you going to use a handheld technique? What is the cannula selection that you're going to use to harvest the adipose tissue? And then, how will you process the tissue? Are you just going to use the Coleman technique and do a microfat and a structural fat graft transfer? Or are you going to create nano fat for more of an exosome or stem cell type of a component? And then, how are you going to inject? Are you going to use a blunt cannula, which is almost always the way we'll inject, other than intracutaneous type injection? But for that, the sharp needle, I think, is the way to go. So microfat, these are kind of like the take-home messages, is something that can be for, you can use a handheld or a power aspiration technique, and you really don't need to do very much processing. The more processing you do, the more trauma to the adipocytes and the less volume you will have. Subcutaneous injection is really the way to go when you're doing a microfat transfer, typically with blunt injection cannulas, and it's really for filling capacity. There is some regenerative component to it, but not as much, as pure nano fat. Now, nano fat, we can also harvest it via handheld or power technique. It's resizing and filtering, so it's more of a process. And again, we're looking for this for intracutaneous injection. I would just say, as a total aside, that we're also using nanofat for orthopedic conditions, and we're helping with musculoskeletal doctors using the exosomes from stem cells, nanofat for that as well. Now, that's way beyond the scope of our plastic surgery discussion, but it has been shown, and we've been really having great results providing nanofat to the musculoskeletal doctors for these orthopedic conditions, which has really been very, very exciting. But again, there's no filling capacity with nanofat. It's really for regenerative capacity. So with that, thank you very much for your attention, and I'm happy to answer any questions that you have, and I really appreciate your allowing me to participate in your conference. Thank you.
Thank you, Dr. Miller. That was a very comprehensive lecture about adipose transfer. And I'm pretty sure that there would be several questions from our participant today. So I'm going to open the question and answering session.
Okay.
Well, if the participant have any question, you are welcome to raise your hand. I see already a few participants. Maybe Dr. Livia. Dr. Livia first, you can.
Okay, good morning, doctor. Thank you for the excellent lecture. I would like to ask about the liposuction procedure in general. Does liposuction is a weight loss procedure, and how much fat can be removed in a single surgery? And the second question is there any absolute contraindication for this particular procedure? Thank you, doctor.
And I'm sorry, the first question was related to would there be a lot of weight loss associated with the adipose removal? Is that what yes?
Yes, doctor. Yes,
yeah,
that's what I'm implying.
Well, yeah, it's funny because the patients will commonly ask about, how much weight will I lose when I get this adipose tissue removed? And I say that adipose tissue is like feathers. So you could take a lot of feathers and it's not going to weigh very much. So don't anticipate that you'll get on the scale and you'll have a big change in your weight from the adipose from the adipose removal. And what was the second question? I'm sorry, can you just clarify that?
Yes, doctor. Is there any absolute contraindication for this procedure?
Well, I mean, these are elective type of procedures, and so, we try to make sure that we want to make sure the patients are healthy. Of course, if they have medical issues such as like diabetes, or they have issues with coagulopathy or other things, then we tend to maybe not do this procedure on them as much. We really try to be careful about it. My chairman in Texas, Dr. Melvin Spira, who there's plastic surgeons all over the world that we love. Dr. Spira, he was one of our best professors ever, and he said that plastic surgery is the only field in medicine where you can take healthy patients and you can make them sick. And so you have to be really careful when you take a healthy patient who's coming in for, an aesthetic request, and you're going to take them to surgery and you're going to make them, temporarily sick, bruised, and, have to recover from the surgery. So we try to be, select the patients very carefully and not, I would say there's no absolute contraindication. There are, of course, but there's a gradient. And as soon as you start to get to, the point where you say, well, there's a significant amount of contraindication, we a lot of times will opt to not do the case, even if it's not an absolute contraindication. It gets to the point where the risk benefit ratio is too high in the way of risk. And so that's how we handle that.
Thank you very much, Doctor.
Sure.
Thank you, Dr. Livia. And also the second participant to raise your hand was Dr. Amira.
Thank you, Doctor. Good morning, Dr. Miller. Thank you for the lecture. I want to ask about the Nano Fat because you said that it was the stem cell material. It can be used to promote wound healing too. And the second is I heard about the other form of the Nano Fat, like cream and needling. And what is your opinion about that? Is it
about like
as injection?
You talk about topical versus injection? Is that what you're saying?
Yes, I heard about like cream, yeah, topical, and the needling form.
Yes.
Yeah.
Yeah. So recently, I would say in the past, year or two, we have started to do a lot of microneedling, and now doing a lot of microneedling with radio frequency. But actually in Shanghai was the first time that Patrick Tonnard had presented his cases where he used this derma stamp, where he did nano fat stamping, microneedling into the skin itself. And then he also created a way to give the patient a jar of their own fat that they would take home and put in the refrigerator, and then take their own fat from the refrigerator in the jar and take it and put it on their face. And we all thought maybe, that was kind of silly or that was eccentric, but then we saw his results and it was amazing. I mean, it was breathtaking. So I have not gotten to the point yet where I'm giving patients their own fat to take home to put on their face. I'm a little bit, maybe that's a little, be a little bit more conservative maybe in the US than in Europe in that regard. But if you ask me if I think it works and if I think it's a good idea, I do. I think it is. So it's a good question.
Okay, thank you. Well, there are a few research, I think, that's using microneedling right now in our center. That's probably why Dr. Amira asked.
Yeah, that's great.
And the next participant would be Dr. Rizka.
Thank you very much, Doctor. Thank you, Dr. Miller. My name is Rizka. I would like to ask, the first one is, what is the prognostic about this nano-fat transfer? What the resorption prognostic, I mean? Does it stay longer than the usual or the microfat transfer? And the second one, in your experience, what is the pitfalls regarding the use of this nanotransfer, especially for resident or who about to start our plastic surgery procedure? Thank you.
Yeah, I think, could you repeat the first question again? I just want to make sure I was clear on that.
About the resorption, doctor. I heard it
Yeah,
will
the
resorb,
resorption. I think,
within months
you know,
or years.
yeah, it's interesting because, you know, microfat in the right place can last a very long time. You know, not necessarily around the perioral area. I think we have more resorption, but like in the breast and other areas, we have a, you know, very, very good, you know, longevity with that. But when you look at these nanofat cases, you know, you can't really tell if there's resorption or not because there's no volume. So it's not like you can get a sense that it's either there or it's going away. But when you see the continued improvement, like of the pigment over like, you know, 9 or 10 or 11 or 12 years, you say, wow, that's quite, you know, that's a lot of longevity as well. So I don't know that there's one that's lasts longer than the other, but it depends on the anatomy and the patient and the way it's done. A lot of it is very technique dependent. And then your second question again, I'm sorry.
I would like to ask about your experience with pitfalls of using these nanotransfers.
I'm sorry, P and what?
Pitfalls of using this nanotransfer, doctor.
Oh, well, I mean, I think that, you know, the key thing is really all the stuff that we talked about, how the, you know, all the harvesting techniques, that there's the type of the cannula, the way that you're processing the adipose tissue. It's a big learning curve. You know, I think that's the thing that is making this so, you know, exciting, but also challenging for us. So we have, you know, certain, you know, pitfalls and certain things that we're, you know, having better success with, but nobody has figured out the perfect way yet. So.
Perfect. Thank you, Dr. Miller.
Sure.
Thank you, Dr. Miller. Yes. So that was several questions already answered nicely by Dr. Miller. There are still several participants. Dr. Ute.
Thank you, Dr. Melati, and thank you very much, Dr. Miller, for your lecture. I'm Ruth, a resident of Plastic Surgery Program of Universitas Indonesia. I have several questions for you. The first one is, do you always use local anesthesia for harvesting the fat graft? And
Yes.
do you use any infiltration before you inject the tumescent, doc? And the second one is, how much do you inject to one region, in example, in the lower eyelid for the nanofat? I mean, what sign you will set that the nanofat is enough for that region? And the last one is, how long is the nanofat last in person?
Okay, so then I'm gonna answer the last question first. So the nanofat lasts, we think we have seen it last longer than, you know, 10 or 15 years and still lasting. So, I mean, I'm not sure it could last maybe someone's whole life, but from the data that we have, we see, you know, continued improvement and changes, you know, lasting more than a decade. So, and then the first question about the anesthesia, and that's a good question, is that I do infiltrate a little bit of lidocaine with epinephrine into the area before I put the tumescent fluid in. So if I'm gonna harvest from a lower abdominal area, I'll grab the abdominal pannus and I'll inject at the base of it, across the base of it, and put maybe, you know, 10 cc's of like 1%, 1 to 100,000 epinephrine into the base of it, and kind of create just above the fascia, pull up the skin, and then you have kind of like a little bit of just general, I mean, just, you know, some local anesthesia that's kind of like sitting there before you put the tumescent fluid in, which of course has lidocaine in it as well. So, and then what was the middle question again?
The second one is, how much do you inject the nanofat?
Oh yeah. So really, when you're injecting in the skin of the lower lid, you know, first of all, it can be a little bit scary the first few times that you do it, because you're really sticking the 30 gauge needle directly into the skin. And I would tell you that it's not uncommon for adipose tissue to nanofat to squirt out of the other holes while you're injecting or through the skin because it's so thin that you're sometimes intradermal and sometimes you're actually coming through the epidermis itself because it's so thin. So my goal is to try to spread out to have an even distribution of the nanofat. Again, you're not really using it for fill. If you're using, if you're trying to correct like tear trough abnormalities and you're trying to address skin of the lower lid, then you can do a microfat injection to do a contour, structural fat grafting, Coleman type technique for the tear trough. And then you can actually inject nanofat into the dermis itself above that level, but different processing technique, microfat for the contour, and then nanofat for in the skin itself. But that, typically that's the way that we do it. I would say probably you're using about 2 cc's, 3 cc's of nanofat in each lid. But for a deep tear trough abnormality, you could be using, 5 or 6 or 7 cc's on each side for contour, correction before you would actually go to the nanofat for the actual injection to the dermis. That makes sense.
Thank you, Doctor.
Thank you, Dr. Miller. We still have a few more questions.
Okay, no problem.
Your topic is very interesting for our resident.
Yeah, it's a hot.
The next question would be from Dr. Ingrid.
Yeah, thank you, Doctor, and thank you, Dr. Miller, for the wonderful lecture. My name is Ingrid. I'm plastic surgery resident from FKUI RSCM. I want to ask, is there any golden or particular range of age that can benefit more from the regenerative effect of the nanofat stem cell? Because as we know, as older people get, the regenerative capacity might be decreased due to aging. Thank you, Doctor.
Yes. Yeah, no, that's a very good question. And the issue with aging is you never see any like really fat old people, right? When people age, they tend to lose their body fat. And so you're right. I mean, there gets to a certain point where, there's not that much adipose tissue to harvest or to utilize. And it is true that from a stem cell perspective, that adipose-derived stem cells have been shown to maintain their activity much more robustly with age than other areas of bone marrow, like other areas of stem cells, like in the body, like mesenchymal stem cells in bone marrow, lose their activity, lose their doubling time, lose their power very early. It kind of tapers off, whereas adipose stem cells, even in elderly patients, they do maintain their characteristics quite well. It's just that it's a kind of a volume thing, and being able to harvest the adipose tissue. So yes, the sweet spot would be, anywhere between, 20 and 50 or 60, depending on the culture, starting to get into this, excuse me, the 70s and 80s, you wouldn't, that's not our fat grafting, fat transfer population. So the more, I'd say the younger patients are definitely better. We also have found that, of course, diabetics and patients with medical problems, we don't tend to do aesthetic procedures on them as much, but their stem cells have been shown to be much less active than in other patients. Even obese patients have been shown to have less active stem cells than normal patients with good BMIs. So you would think obesity, maybe the more fat you have, the better, more stem cells you have. That's not necessarily the case. So, but good question.
Thank you, Dr. Miller. So obesity with a lot of fat tissue doesn't exactly correlates with the number of the stem cell inside their fat. Okay.
True. Yep.
So we still have a few questions from Dr. Reinhardt.
Yes, thank you, doctor. My name is Reinhardt also from the Plastic Residency Program in FKUI. Thank you for the lecture, doctor. I was wondering if there is other potential uses for the nanofat transfer other to correct the irregularities in the lower eyelid, doctor. Thank you.
Yes, it's a great question, and absolutely. I mean, autologous, adipose, exosomes, and stem cells, you know, are being used for many things. I mean, in oral maxillofacial surgery, for gingival, you know, regeneration, working with Dr. Marks, who's really one of the pioneers of PRP and a master in the world of maxillofacial surgery. He and I just wrote a textbook on stem cells and regenerative medicine. As a matter of fact, you guys can get this on Amazon. It's Marks and Miller. And it's the book that I just published. There's amazing authors like Tony Atala, Rocky Tuan, many people in the world of plastic surgery, including Dr. Greg Evans and others. But it's a multi-specialty book that goes into the basic science of stem cells. So it goes into all of the, you know, physiology and looking at all different sources, adipose, perinatal tissue, bone marrow derived stem cells. So there's a lot of basic science. We also talk about cell expansion. We talk about cell regulation with the FDA, tissue banking and other things. And that's about 1/3 of the book. And then 2/3 of it is for all hard and soft tissues of the body. So it's dental, maxillofacial. Dr. Marks is the king. We're known around the world and really an expert in that. And it's really overlaps with our specialty. Then we have plastic surgery, dermatology, and there's a huge section on musculoskeletal, which is written by authors from Mayo Clinic, Dr. Jim Andrews, excuse me, who is like the NFL sports medicine orthopedic doctor, you know, that is like the most famous in the world. They're all chapter authors. Anthony Atala, who is the chairman of the Wake Forest Institute of Regenerative Medicine. Rocky Tuan, who was the chairman of the stem cell unit at the University of Pittsburgh, the orthopedic stem cell unit. So that textbook really highlights the answer to your question. It's a very long answer to your question, but there are huge applications. And you know, one of the things I think that's so important and is really the future is collaborating with your other specialties. You are the masters of the adipose tissue. You are the providers of the material that can cure osteoarthritis, cure COVID lung disease. I mean, still answering your question, in University of Copenhagen in Denmark, there's a cardiologist who has a chapter in this book, and all of the adipose tissue from the country that is harvested by plastic surgeons goes to his lab as a cardiologist. And then he is the director of the stem cell lab, cardiology lab at the University of Copenhagen in Denmark. He takes the adipose tissue, dissolves the fat, and then expands the stem cells and uses them for cardiac injections in the country of Denmark with government approval through formal INDs. So your question about, are there other applications, it opens up this whole world of possibilities, because the mesenchymal stem cells in adipose tissue it's really the richest source and the best source of stem cells, but people don't know how to get adipose tissue. We do. So we can really, work with the orthopedic surgeons, work with the maxillofacial surgeons, work with the dermatologists, and even provide adipose tissue for the formal university INDs as a source of adipose tissue for these cardiac injections. We've had several major COVID clinical trials in the University of Miami where patients have gotten off of the ventilators and cured of COVID lung disease with stem cells from fat, stem cells from bone marrow, and stem cells from umbilical cord. The source doesn't matter that much. That, the adipose is definitely the most plentiful, but this just shows, that we are the gatekeepers, the providers for this tremendous material, where we have the expertise to harvest it in such a way and provide it to these other doctors for all these different other applications. So my compliments to your question. It's an excellent question, and I'm sorry for the long-winded answer, but you have many, many possibilities for your team in Indonesia in the same regard.
Yes.
Good question.
Thank you, doctor.
That was actually quite inspiring for us also. So I guess we could actually go through with the lecture next time more about stem cells, right? So
We absolutely could. No problem at all. My pleasure.
thank you, Dr. Miller. So we could continue with we still have a few more questions. Dr. Alita. Dr. Alita?
Hi, Dr. Miller. Good morning from Jakarta. My question is a bit related to what Reinhard just said. Would there be any studies that have applied this nano fat application to the healing and to add the regenerative capacity of burn patients and other wounds that may have ongoing healing process? And the second question, my second question is, would you be able to store these fats that you have harvested to be used at a later period? Thank you.
Yes, thank you for the questions. The first question, my experience has been mostly with chronic, burns that are not acute in the acute injury phase, where patients come in with large, even tremendous keloids, or having had contractures of their mouth, or not being able to wear glasses because their ears are burned to the side of their head. And we've had really, really great success with the injection of nano fat in the subcutaneous areas underneath the scar tissue, and combining that with PRP, platelet-rich plasma. We've been getting really, really good results with that. What kind of applications it has in the acute burn phase, I would say that I'm not as experienced in that, and I don't know. I know that there are PRP gels that are antimicrobial, and that there are, some different applications for regenerative therapies in the acute situation, just like there are with acute, MIs and with, cerebral CVAs and things like that. But I'm just not, and that's not as much my area of expertise as seeing these patients come back from the burn unit, years later, that's, are having really significant problems. So I've been doing more of the chronic work. But I do think I would imagine there are some roles for acute burns and different sprays and topical applications of keratinocytes and some other things that are, definitely in the pipeline for the acute setting. And then as far as storing the tissue, in the US, we if you're storing tissue, you're a tissue bank. And the FDA draft guidance documents really support the concept of a single same-day surgical exemption. So if you're using this, adipose tissue and you're transferring it the same day in the same patient in the same room during the same procedure, then it's considered the practice of medicine. And if you start to, take that adipose tissue and store it in the freezer and then use it another day, then that's more of something that's related to tissue banking itself. Thank you for questions.
Thank you, Dr. Miller. That was actually very good answer. And I would actually ask a few more questions from myself about what you mentioned about the chronic burn. So you have experience using this nano fat combined with PRP, injecting under the in the subcutaneous level for the chronic burns.
Yes, for chronic burns and also for keloids and hypertrophic scars. And I just saw a patient today who's actually in one of the chapters in the book, and he's a black gentleman. He had a lime burn from lime, more like a chemical burn, but had some really severe burns. And he had two areas where I explained to him I was not sure if removing the scar and injecting nano fat and PRP at the time that you excise the scar and close it, or if just simply injecting underneath the scar with the blunt cannula would be a better approach. So he let me try one technique on one scar and the other technique on the other scar. And he gave me permission to experiment on the same arm. And as a surgeon, I would tell you that I was very disappointed to say that the surgical side was way worse, healed much worse scar than just simply using a blunt injection cannula, combining adipose and PRP and injecting underneath in the subdermal space. That was what really made the other scar look much better afterwards. And today I reminded him of that experiment. It was probably about 10 years ago. And he said, well, you have to learn, doctor, you have to learn. And I said, well, thank you for, allowing me to, do this. Now I realize for future patients and for your patients, you can avoid the pitfalls that I made and just not cut those things so quickly, inject them instead.
Definitely a good experience from you. Thank you, Dr. Miller. We still have a few more questions.
Okay.
So maybe Dr. Amila?
Thank you, Dr. Melati. Hi, Dr. Miller. My name is Amila, one of the plastic surgery resident here in Jakarta. I want to ask, in your personal experience, do you have any challenges in performing nanofat transfer? And the second question is, I saw your 15 years follow-up on a patient with the excellent result. Do the nanofat injection should be re-injected? And if it needed re-injection, how long is the interval in every injection? Thank you, Doc.
Sure. Well, I mean, we have really seen that the nanofat injection has been kind of like a one and done phenomena. We keep seeing improvement. Now, I can't really comment for like the musculoskeletal patients and the people that were the other applications that were using nanofat, but for the cutaneous applications, we have had success to the point where we just don't feel the need or there's any indication to go back in and inject it again. That seems to be the common, scenario for that. And then could you remind me your first question again?
My first question is, in your personal experience, do you have any challenges in performing nano fat transfer?
Oh, yes, many challenges. It is very challenging. I mean, the concept of emulsification, of resizing the adipose tissue, using smaller syringes gives you more pressure. So, for example, if you try to use a 10 cc syringe and squirt nano fat, it may not come out of a 27 gauge needle. But if you use a 3 cc Lurlock syringe, you get a lot more pressure in a smaller size syringe. So you can get the nano fat out through a smaller size needle. That's very important a lot of times for our spine surgeons that are using nano fat. We're helping prepare that, and they're trying to get it into the spine, into a disc with a very small, with a very small needle, and you can't do that with a big syringe. That's one thing. There's everything from the harvesting to the cannula selection. There are many, the learning curve is really very steep. And, I do a lot of training of plastic surgeons who are learning the technique, but I also work with a lot of people that have, never worked with adipose tissue, like, orthopedic surgeons and maxillofacial surgeons. So I'm trying to simplify the process for them. I don't think it's realistic for them to be calling us for every single case that they do. Right now, they're absolutely, clueless. They look at a cannula, they think it's like something from outer space. They're just, fascinated by, and we are so familiar with, utilizing that. But at the same time, it's a humbling process. And I would say I'm still trying to refine the technique to make it, smoother and better every time. One of the most common pitfalls or mistakes is that people do not tumesce the tissue for long enough. The epinephrine in the Klein solution, it really should be in that tissue for like 20 minutes, and it should just sit there. And for example, my orthopedic surgery friends, they're so impatient. They call me and they say, "Oh, there's blood. There's so much blood in this fat." And I say, "Well, how long did you let the tumescent sit there before you aspirated the fat?" "Oh, 5 minutes, but it seemed like it was like an hour. It took just like, it was just, two." And so, so I tell the nurses, you need to distract the doctor. You need to bring him out of the area where he put the tumescent, and you need to have him like read the newspaper for 10 minutes or do some paperwork and then come back. And so, because that is allowing that epinephrine to constrict those blood vessels, it's even a big difference between 15 minutes and 20 minutes. 20 minutes is really the sweet spot for that. But I'd say that's one of the more common, errors, is to try to go in there too quickly and get the adipose tissue. And then we have a lot of blood in your harvest that really doesn't really, it's not as good of a good quality harvest, of course.
Thank you, doctor, for sharing your experience.
Sure.
Thank you. That was a good tip also about the nurse. Okay, thank you.
So you have your mask on now?
Yes, because I'm preparing to go to the hospital.
Okay, I just want to make sure it's the same person.
It's still the same person, Dr. Miller.
Okay, that's good.
Okay, we still have a few questions, which is from Dr. Narotama. He is also one of our junior staff here. Dr. Tommy.
Yes. Hi. Good evening there, Dr. Miller.
Thank you, sir.
Nice to meet you, although virtually, of course. Well, I'm hoping that I can visit you sometime in the future. I think it will be a great experience. For our center. So yeah, Dr. Miller. Actually, my question is about the combination of fat graft and PRP, just like Dr. Putri there has asked. So Dr. Melati, I think you sort of read my mind there. Question about PRP. So initially, my first question would be, how do you think on the effects of the PRP in combination with the fat graft? Of course, you've answered that because you've had that experience on using both on the combination for the scars.
Yes.
And yeah, of course, because some studies actually stated that the combination between PRP and fat graft actually have a positive effects, that the fat graft survivability is actually increased because of the PRP.
That's
yeah.
correct.
So what is your take on that? So and then the second one, Dr. Miller, is about the technique. So how do you use the combination between the PRP and the fat graft? How do you inject those two materials? Because you mentioned that you actually do not combine those two materials within one injection. Thank you, Dr. Miller.
Those are some veteran questions right there. I love that. So basically the synergy between adipose and PRP, has been well described. It minimizes apoptosis. It enhances engraftment of adipose stem cells. There's no question, and adipocytes, there's no question that it's really a benefit. One of the things that's a little treacherous is that PRP is mostly in the orthopedic literature. It's really not in the plastic surgery literature. And there's so much controversy on whether PRP is effective or not. But then when you look at how the PRP is prepared in these different articles, you realize that they're not using any kind of like standard technique, and they're just doing things that are way different than what we would consider to be the standard preparation of PRP. So the problem is that PRP is, instead of buying a commercially available kit that could cost, $200 and provide you with, relatively constant product, a lot of the musculoskeletal doctors are spinning a tube of blood, and they're just turning their head sideways and saying, oh, that's the Buffy coat, that's the PRP right there. And that's just not really a scientific way to, analyze it. So when it's real PRP, and Dr. Marks is, again, one of he's really the first describer of PRP. And one of his articles that he wrote is called PRP is not PRP is not PRP. And it's very true that, just because you use those letters doesn't mean that it's really the same thing that we're all talking about. But the real PRP, there's no question in our minds that it is something that's very, very synergistic with the adipose grafting. As far as the technique, wow, that's been the most humbling for me. Because plastic surgeons don't use PRP, and so this is one of the benefits of collaboration with your other specialties, is I started working with these musculoskeletal doctors who were asking for adipose tissue. So I show up, they're my friends, my tennis buddies, so I go and we do cases, and I get the adipose tissue, and I look at the equipment, and I say, what is that? And they said, that's a centrifuge. And I said, that centrifuge for what? And they said, that's a centrifuge for PRP. And I said, what is PRP? I never heard of it as a plastic surgeon 10 years ago. I never heard of PRP. And they're like, oh, that's a platelet-rich plasma. It's been used with bone marrow derived stem cells for the last 15 or 20 years. It's very, very popular. Thoracic surgeons are using it in the closing up sternotomies to minimize infections. So I learned PRP from being outside of the world of plastic surgery. And even when I go to ASPS, people barely talk about PRP. It's not even like really brought into the conversation, but it's really, in my opinion, it's huge for regenerative medicine. And bone marrow stem cells in PRP are like salt and pepper. I don't know how it is in Indonesia, but like when you eat, you sit down, it's never just pepper, it's never just salt. There's always salt and pepper. There's always PRP and bone marrow derived stem cells. So I'm thinking, well, maybe there's PRP and adipose derived stem cells. That'd be great. The problem is that it's a whole different science, but when you activate PRP, that's the classic teaching to get the platelets to degranulate and to release all those growth factors. Typically that's done with calcium chloride. And as soon as you activate PRP, it starts to clot and it gets very difficult to get out of a syringe to inject it out because it's clotted. So like an idiot, I, in my first couple cases, thought, well, geez, I'll just take the whole syringe of fat and I'll take the whole syringe of PRP and I'll mix them up and we'll have a great case. And then I mixed them up and I realized that we have no tissue, no biologic to use because it's coagulated inside the syringe, these big syringes, and can't get it out. So I teach that, like, if you're doing hair restoration or you're doing several burn scars, that you have your adipose tissue separate, nano fat separate. So the nano fat is produced and your PRP is produced, but you don't let them touch each other until you're ready for action. So if you have 5 burn scars and you want to inject some adipose and PRP, you take a little bit of adipose, a little bit of PRP, you mix it up real fast and you inject it real fast, like within 20 seconds, 30 seconds to make sure it doesn't coagulate. And then you have the separate syringe of PRP, still anticoagulated. You have your nano fat, separate. But when the nano fat touches the PRP, it activates the PRP. It's a great activator. And one of the things I think would be a really good research study, and maybe I would be happy if somebody's interested in, collaborating and doing something like this, is, activating PRP. If you activate PRP with adipose tissue with nano fat, what kind of activation does that give you? What kind of growth factors do you get from that versus activating PRP with collagen or just activating PRP with calcium chloride? So I think, as we go down the road, we'll be looking to see, what are the best activators, but there's no question that as soon as the PRP touches the adipose tissue, it starts to activate and it starts to coagulate. And that's where it's very steep learning curve to understand to keep them separate and only combine them right at the point where you're about to use it. So that's an excellent question. Appreciate that.
Wow, really great. Dr. Miller, that's some heavy stuff there. So
yeah, that's about 15 or 20 years of experience there in
yeah.
about 2 minutes.
well, hopefully more research and publications could come from that, of course, Dr. Miller, and some collaborations perhaps in the future. Really great. Yep. Thank you very much, Dr. Miller, Dr. Melati.
Thank you, Dr. Miller. We have our question also from our resident here. She is one of the newest resident, Dr. Avanti.
Hello, good evening, Dr. Miller. Thank you, Dr. Melati, for the opportunity. And thank you for the very good presentation. It's very interesting. My name is Avanti, and I am on a residency program in FKUI. I have like a little question about, as you mentioned before, about the not really good outcome and not really good stem cell on a person with a geriatric patient and obese. I want to ask you how to overcome that. And then the second question is like, because the fat is a stem cell, and is it possible that you can transfer the fat from other person to another patient? And if it's possible, is there any complications, and how's the result? Okay, Thank you.
Okay, good. Yeah. Well, for a new resident, there's two very good questions there. So the first one about the geriatric patient and obese patients and how to overcome that. Really, the only way to do that is to provide some kind of exogenous source of cells. These days we're looking at lots of manufacturers of things called exosomes, which are the messengers from stem cells. And maybe it will be possible to open up a vial of exosome and give that for a geriatric patient with osteoarthritis or with some kind of condition, or maybe even a cutaneous condition as well. So that's something that we definitely have to be able to have some treatment options if we don't have autologous tissue. And then regarding your second question, it's very interesting because the stem cells, they don't have any HLA markers. So I could use my stem cells on you and you would not reject them and you would have no rejection whatsoever. However, the adipocytes and the other cells in adipose tissue do have HLA markers. And with HLA markers, that's where you would get rejection, of tissue and not be able to transfer it from one person to another unless they were genetically exactly the same. So for the adipose tissue, it's tricky, but for stem cells, there are tissue banks with stem cells where there are master cell lines from other people, and they are used in other patients, with no rejection. And as a topic for another day is that stem cells actually induce immunotolerance. So people that are having graft versus host disease and having big issues with rejection of grafts, the treatment is actually to give them IV mesenchymal stem cells, MSCs, give them IV. And there's people like at Walter Reed and at NIH, and they're doing some pretty cool studies right now using stem cells to induce immunotolerance, not immunosuppression, but immunotolerance of certain grafts. So good question.
Thank you, Dr. Miller. Yeah, thank you, Fanti, for your question. We actually still have another question. This is from my senior staff, Dr. Parintosa. He's writing the question in the chat, but maybe Dr. Parintosa would like to deliver the question himself. Dr. Ocha?
Okay. Thank you, Dr. Malti.
Hello, Dr. Ocha.
Oh, sorry. Thank you, Dr. Miller, for the very inspiring lecture. I will ask about this is very basic, I think. There's three questions. My first question is about do you perform more amount of nano or micro fat graft for reconstruction like the macro fat graft in the past to prevent the decreasing of the result? And then the second question about the plane. We know that the best vascularized plane in the skin is in the subdermal plexus and also in the muscle. So in the large amount of fat graft or fat transfer, like in the breast reconstruction, where's the plane that you inject the fat? We know that if we inject the fat into one plane, there is some tissue will be die because there's not contact with the best vascularized environment. Do you also inject the fat in the muscle for this case? And also I want to ask and appreciate about your very nice cases, but it is all cases of it is all of your cases perform only in one surgery. So, and if we need to perform the revision, how long about the interval for the revision? Thank you, Dr. Miller.
Absolutely. So I would say for the revisions, we wouldn't operate on somebody probably for a good 12 to 18 months and really give things a chance to heal well, before going and jumping back into a revision surgery. Is regarding fat transfer and into particular areas. For example, in the breast, I do think it's a very good idea to inject both in the subdermal area and also in the fascia and the premuscular fascial area. We don't really advocate injecting, as you know, into the breast tissue itself. But I have found also that I have gotten great results with intramuscular injection of adipose tissue, as well as into the fascia on the surface, and then in the subdermal plexus as well. So for me, I think that the muscle is a great recipient bed for adipose transfer, and I would highly advocate that. And could you just remind me your first question again one more time?
I want to ask about the amount of the injection of the micro and nano fat. We know that if we inject or placing the macro fat, we need the more amount to prevent using the graft.
I got you. Yeah, absolutely. I mean, I think the microfat is really for contour improvement. And so that's where you really need, cc's. So for example, in a lower lid, if you're going to inject maybe 4 or 5 or 6 or 7 cc's into the tear trough to get that correction. But then if you're going to inject nanofat into that same area and you're going into intradermal injection, then you're really going to only be able to get, like a cc of nanofat really into the dermis, truly into the dermis itself. So it's always more microfat when you're doing contour and doing a volume type of approach versus the nanofat with the regenerative approach. It's typically less. We'd like to get more of the nanofat in, but after a while, the dermis is only so much, can only receive so much before it squirts out of another hole or that kind of thing.
Okay, good, perfect. Thank you, Dr. Miller.
Thank you. Yeah, thank you.
Dr. Miller, for the wonderful session and wonderful answer for our never-ending questions from our resident and staff. I would also like to say hello to everyone, and I also see from the participant, aside from our plastic surgery resident, there are also alumni from our plastic surgery residency. Many of them are also my seniors, and also we have our head of plastic surgery here, Dr. Aditya, and there are Dr. Devi, Dr. Irena Sakurarini. Hello, Dr. Irena. She's our head of our plastic surgery association in Jakarta, and also a leading reconstructive surgeon in National Cancer Hospital, and also a very prominent aesthetic surgeon.
Wow.
Dr. Irana, and also Dr. Indinawati, and I still see a few more names. I hope I didn't miss any. But before we conclude our lecture today, maybe we could take a group picture.
Sure. I don't know how you do that, but I'd love to. Sure.
Oh, the host will take a screen capture, but maybe the participant can also open up their video first, so we can take a good group photo.
So do I need to do? Do I need to do anything, or
you need to smile?
Okay. Okay, that's good. I can do that.
Okay, everyone ready for the photo?
Oh wait, here. Let me take my glasses off. Okay, that's good.
Okay, 1, 2, 3. Okay, for the first page, and let's go to the second page. Okay, 1, 2, 3. Okay. Everyone is already taking photo.
So you could send that to me?
Of course, I will email it to you.
Awesome. Thank you.
Thank you so much for the first lecture from you, and hopefully we could continue next month, probably on the second lecture and so on, and maybe other collaboration that we could discuss through email, I hope.
Sure.
Thank you so much. And I also would like to say thank you for all the participants and their eager questions.
Me too. Me too.
That made this lecture very lively, I think. I hope we can see each other, not just virtually, but maybe in the next year, probably
That would be great.
offline, I hope.
Me too.
Thank you so much, and wassalamualaikum warahmatullahi wabarakatuh.
Waalaikumsalam warahmatullahi wabarakatuh.
Thank
Thank you
you,
very much, Dr.
Dr.
Miller.
Bye. Thank you.
Okay,
Dr. Miller.
bye-bye. Thank you very
I
much.
hope you have a safe trip home.
Thank you very much. Good day at work as well. Take care.